Good afternoon, President, Association of Physicians of India, Dean, Indian College of Physicians, President, Sri Lanka College of Physicians, all my dignitaries, faculties from the India and neighboring country, India, Nepal, Bhutan, Bangladesh, and Sri Lanka, and my dear students. With the Indian leadership many days, many years, we thought that like other specialty, India should have or regionally on regional forum consisted of the following countries so that we can mutually exchange our ideas or students of one country may be benefited from the knowledge from other countries and bilaterally all countries will be mutually benefited. From that viewpoint, I discussed with our respected president and also the past president, Professor Kamlesh Tiwari, current president, Professor Shyam Sundar, also with past dean, Dr. Rajesh Subadhyay, and current dean with Madam Alka Deshpande. They have given kind consent to start the joint academic forum consisting of these all neighbor 5 countries. So this is the second of such of master class. COVID has taken many lives, taken the economy, but at the same time have given a beautiful technology by which sitting even 1,000 kilometers away, we can be connected and we can discuss many things. So in this webinar of the master class of the SAARC countries, first I invite Professor Shyam Sundar. He is the president of Association of Physicians of India. And Dr. Shyam Sundar is very well known, needs no introduction because in Harrison's, the only Indian who is written chapter that is on Kalajar, he is Professor Shyam Sundar. He is retired as a professor and head Department of Medicine of Banaras Hindu University. Then I invite Professor Alka Deshpande. He was also ex-professor of medicine and currently he is Dean Indian College of Physicians. I invite Professor Ganaka Senaratne. He is MBBS, MD, MRCP, Acute Medicine, FRCP, and Head Emergency Medicine, Karapitya Teaching Hospital, Sri Lanka. And he is the respected president of Sri Lanka College of Physicians. I invite Professor Jagdish Prasad Agarwal. He was the ex-professor of neurology, ex-dean Institute of Medical Science, Kathmandu, Nepal. He is a member Medical Educational Commission of Nepal. He is the executive director of National Center for Health Professional Education. I invite Dr. Sanjeev Bautha. He is the MD, MBBS, MD, MRCP. He is a senior lecturer in medicine, Dean, Faculty of Medicine, and acting as a Vice Chancellor, Wamangto University of Sri Lanka. Professor Guru Prasad Dhakkal from Bhutan. He is a Department of Medicine and Gastroenterology, JWWNRH, Thimphu, Bhutan. I invite Professor, my very good friend, Professor Aminur Rahman. He is a neurologist and to Indian students, he needs no introduction because he has taken several classes in master class on CT and MRI brain. Dr. Aminur Rahman is a fellow of interventional neurology and he is a clinical interventional neurologist and medical specialist. He is the assistant professor, Department of Neurology, very young. Sir Samimullah Medical College, Mitford, Dhaka. Mitford is one of the historical college in Dhaka and pre-independence, it was uttered in the same breath with Mitford, Calcutta Medical College and Madras Medical College, the oldest 3 medical college of this subcontinent made by the British. I invite Dr. K. Mugundan. He is the MD, DM, MRCP, Head Neurology, Government Stanley Medical College, and he is also governing body member of API. I invite my very good friend, Dr. Palani Appan. He is also Vice President of Association of Physicians of India and a consultant physician from Madurai, Tamil Nadu. Next, I invite Professor M.K. Roy. Professor M.K. Roy is an ex-professor of neurology from Calcutta National Medical College, and he also past member of the Indian College of Physicians and was the ex-joint secretary of Dean's Place. And this masterclass actually is brainchild of Professor M.K. Roy. I invite my Dr. Jayant Panda. He is the professor and head Department of Medicine of SCB Medical College, Cuttack. I invite Dr. Dijen Das. He is the associate professor in medicine of Tejpur, Assam. I invite Dr. Shekhar Chakraborty. He is also consultant physician and governing body member from Siliguri. I invite Professor Udas Chandra Ghosh from Kolkata, Professor P.P. Mukherjee from Kolkata, and last but not the least, my co-convener, Professor Nandini Chatterjee. He is the professor of medicine of SSKM IPGMR Hospital and also associate editor JIMA and editor of Bengal Physician Journal. And without her help, it was not possible to conduct webinar. So with this brief introduction, now I request Professor Shyam Sundar, President API, sir, say few words.
Thank you, Professor Jyotirmay Pal. Dear members who have joined now, presidents of various countries, physicians forum, and fellow delegates. It is really a great pleasure that this kind of event has been organized. This is for the first time that somebody has thought of the international cooperation involving SAARC countries for physicians. And I really congratulate Dr. Jyotirmay Pal, Dr. M.K. Roy, and others who took this initiative to have this forum, and we'll have tremendous benefit of this. We can exchange the ideas, we can exchange, we can invite the people from SAARC countries, and we can be invited. So, I mean, this is really a very big advantage that we have with this forum. And I wish it a great success. And I hand it over back to Dr. Jyotirmay Pal.
Thank you, sir. Thank you for your kind word. Now I request Professor Alka Deshpande, Madam, say a few words.
Hello.
Hello,
Good
madam.
afternoon, everybody.
Good afternoon,
madam.
ma'am.
You are audible.
Am I audible?
Audible? Yes, madam.
Yes, ma'am.
Okay. First of all, I am thankful to Dr. Jyotirmay Pal for giving me the opportunity to meet all these people on one platform. Indian College of Physicians is an academic wing of our National Association of Physicians. And I'll be, at the moment, I am the Dean, and I'm really privileged to welcome all the delegates, particularly the experts from across the border for this forum. I welcome them all. And I'll be very happy if the physicians from these countries become the fellows of our Indian College of Physicians. With globalization, we all have come so close to each other that nobody can remain isolated. And that is what we have seen through all these pandemics. So it is necessary that we exchange our information, knowledge, and expertise amongst ourselves. We have to move forward. And that is why I congratulate Dr. Jyotirmay Pal and his team to get the people or the experts from across the border. Will definitely be benefited by their experience and expertise. And at the same time, we have experts across the country. So I wish a great success to this program, and we will have many more such programs. And once again, I reiterate that the physicians from these countries should really join hands with us and become the fellows of our Indian College of Physicians. Thank you very much.
Thank you, madam. Thank you, madam, for your encouraging word. Now I request President Sri Lanka College of Physicians, Professor Ganaka Senaratne, please say few words and how we can proceed further. Professor Senaratne, please.
Right. Good evening, everyone. Dr. Shyam Sundar, President, Association of Physicians in India, and Madam President and Dean of Indian College of Physicians. Dr. Rahul Alam, President, Association of Bangladesh, and Dr. Arun Mukherjee, President, Simcon Nepal, and all the respected dignitaries in the panel. So it's been a pleasure to join this joint academic forum. Sri Lanka College of Internal Medicine would like to thank profoundly the Indian College of Physicians and Association of Physicians of India for inviting us to be a part of this very important postgraduate masterclass. We thought it's a fantastic idea to have a common forum for all of us in South Asian countries. And we believe our residents and postgraduate trainees would benefit immensely by participating in this program. My profound thanks goes to Dr. Jyoti for his personal, enthusiastic, and energetic support extended to us from the beginning, the day he contacted us, I think about a month ago. So it's been really a pleasure to work with him and the whole team. I have Dr. Sanjeev Bowatta, Dean Weinberg Faculty of Medicine, participating as expert panel today. Thank you very much, Sanjeev. And I wish all, we believe that we will be able to get our residents also to present in this very valuable forum in time to come. I assure that we would do that. So I really wish really very best for this forum and congratulate both societies for putting up this such wonderful program. Thank you very much.
Thank you, sir. Thank you. Now I request Professor Jagdish Agarwal from Nepal. Sir, your vision on this forum. Dr. Agarwal?
He's muted, no?
Muted. Oh,
yeah.
Otherwise,
good evening.
Yes.
Good evening
Yes.
to everybody.
Yes.
Professor Shyam Sundar, the president of API, and the other presidents of from different countries representing the internal medicine faculties and societies. First of all, I'd like to congratulate for starting or taking this initiative to bring us together. And our president, Dr. Arun Maske, who is the president of Simon, Society of Internal Medicine of Nepal, has asked me to represent this forum for this master class. So I'm here and I'm thankful to Dr. Professor Pal for giving us an opportunity. And I wish that in days to come, we can share our academic know-how and the skills so that our graduates and postgraduates, they can do better and serve the people better. Wish this master class a success. Thank you.
Thank you, sir. I am very lucky to have Dr. Guru Prasad Dhakkal. He is from the same college, Calcutta Medical College. Now he is working as a dean in Bhutan. So, sir, say a few words.
Thank you, Professor Jyoti, for the introduction, and honorable professors from India, Sri Lanka, Bangladesh, and Nepal. A very good evening from the Himalayas. Indeed, it's a great privilege and honor to be part of this August forum, Associations of Physicians of India. Bhutan is unique in that regard that we have physicians from all these countries who have been trained in different countries. We are from India, we are from Sri Lanka, we are from Nepal, we are from Bangladesh. So in fact, it is a big honor for us to be part of this August gathering. I would like to thank Professor Jyoti for going out of the way and linking us, because I think it was very difficult for him to find someone from Bhutan. So somehow he managed to get my address and then he has included us. We also have the postgraduate program in Bhutan in internal medicine. We take 2 residents every year, and we have already had 3 batches who have passed out. So the residents will definitely benefit from this learning platform. Thank you very much. And we would like to once again thank all the professors and Professor Jyoti for giving us the opportunity to be a part of this forum. Thank you very much.
Thank you. Thank you. Dr. Aminur, will you say something? Dr. Aminur Rahman from Bangladesh.
Thank you, Professor Jyotirmoy Paul. He's my big brother, and he always invite me in such a academic session in India and also other part of the world. And he's very much admired person about me to me, and I'm very much delighted to attend this such kind of postgraduate master classes. And I'm also thanks to all the faculties and who give me the chance and who utter my name as a panelist in this session. And I hope so. This program will be continuing in the future, and this will be benefited also in my country and also other sub countries in this subcontinent. So I've set up say special words to Dr. Jyotirmoy Paul's Dada for this such kind of fun. Thank you.
Thank you. I included you with the demand of the student because students cannot forget your class on CT scan, brain and MRI. So excellent 6 classes you have taken during the COVID period. Thank you. Thank you. So with permission of the chair, so now we are going to start the actual case discussion. And we have our junior resident, Dr. Rimjhim, to present. Professor Nandini, now you start the proceeding. Professor Nandini Chatterjee, please.
Rimjhim, are you there?
Yes, madam.
Yes, we have our resident from National Medical College, Kolkata, Rimjhim Bosha. She is going to present an interesting case, and we will be having a discussion on various aspects of this case. So I think you should begin.
Rimjhim, you share your slide.
Good evening, my respected teachers, seniors, juniors, expert panelists, and delegates.
Mrs. Sharmila, please start recording.
It's recording, sir.
Okay.
Good evening, my respected teachers, seniors, juniors, and expert panelists and delegates from some countries. I would like to present a case of a lady with a Lurch. 25-year-old female Muslim coming from Rakhalganj, Nodia, homemaker, was admitted in our college on 1st of April 2022. Her chief complaints were difficulty in walking and balance for last 4 years, tremulousness of limbs for last 4 years, and slurring of speech for last 4 years. Coming to history of present illness, her difficulty in walking was insidious onset and gradually progressive, present for last 4 years. She had a tendency to fall on either side, and her difficulty walking, which started on walking on a narrow passage. For the last 2 years, she has been unable to perform activities of daily living owing to the severity of the disease. It was not associated with worsening of symptoms during night, not associated with vertigo or tinnitus.
So I would like to talk. I would request Professor Mrinal Kasi Rai. Sir, are you there? Sir? Professor Rai?
Hello. Am I audible?
Sir, are you there?
Am I audible? Okay.
Yes, you are audible. Sir, so
am I audible?
You
Yes,
are
yes.
Yes, sir, you are audible,
You
sir.
are not properly audible. Dr. Hemkira is audible.
okay.
Okay.
So, sir, she has described the complaint of the patient. So, I would like to ask you first that difficulty in walking and balancing, what it signifies in medical terms, and what is ataxia, and what are the different types of abnormal gait?
Thank you, Dr. Professor Chatterjee. So she is complaining of difficulty in walking, and you were asking me in the medical terminology, we can say that probably it may be due to some sort of an imbalance or loss of coordination. So the ataxia is the proper term. We usually use the term ataxia in medical terminology. Ataxia means that the patient cannot keep his or her balance, what is supposed to be during the process of locomotion. And as a result of which the patient may fall on either side, maybe in the forwards or in the backwards. So basically this is ataxia. So this is the term. Now you have asked me the second question. What are the types of gait? What is your second question?
That what are the different types of abnormal gait?
Abnormal gait. Okay, fine. It's a very important question for the postgraduate especially, because this is a very basic thing. We must know how we maintain the gait and what are the abnormalities which can take place in the background of an abnormality. So to maintain the gait, you need when we stand, we need the activity of the anti-gravity muscle. We all know, and there is a definite coordination between the different systems of our body, especially from the cortical area, higher level, to your vestibular apparatus, to your optic apparatus. Then we have the proprioceptive sensations from the posterior column, and also the intact peripheral nervous system, as well as the musculoskeletal system. And last but not the least, it is the cerebellum, which is very, very important in maintaining our gait. Now, if you have got any problem in any part of this neuroaxis, be it in the periphery, be it in the mid-level or in the higher level, we can have different types of gait. So number one gait we commonly come across in our clinical practice after a hemiplegia, we call it is a cerebellar gait or cerebellar ataxic gait when there is a problem with the cerebellum. Then it will be in very wide stance, steps taken very slowly and carefully. There is a tendency to lurch and stagger. And this is very important that it is accentuated by your tandem walking. So this is a very classical of the cerebellar gait. Now, when we think in terms of your sensory gait, that is also a wide-based gait, but the patient will have a broad base, and on closing the eyes, patient will immediately fall or it will increase the unsteadiness. And there is advancement of the patient with locomotion with very cautious. Patient is always cautious. He will try to see the gait downwards. Steps, slow steps under visual guidance. And sometimes it is a slapping in quality, slapping sound you can get. Now, we all know what is a Rombach test. Rombach sign is positive in sensory ataxia. So in Rombach test, what we do is that we ask the patient to stand with the feet close together. And after that, we just ask to stand properly. Then we ask for closing the eyes. On closing the eyes, hands will remain by the side of the body in anatomical position. On closing the eyes, the patient will immediately fall. So Romberg will be positive when the patient falls. Just by swaying is not Romberg. But the falling of the patient on that particular position will be considered as a positive Romberg. Third important point, there is difficulty in walking on an uneven surface. So this is a very characteristic of a sensory gait. Now, if we think about the other types of gait, like after a stroke, we commonly come across with a gait which is known as a hemiplegic gait. In the hemiplegic gait, what is more important to know is that the patient foot is actually inverted. You can take this way. This is not necessary. This slide is not necessary. Who is taking the slide? Who is actually running the slides? Am I audible?
Yes, yes.
Am I audible?
Yes, yes.
Nandini, am I audible?
Yes, yes, audible.
Yes. You're audible, sir. You're audible.
Am I audible?
Yes.
Sir, may I speak?
Am I audible? Am I audible?
Yes, yes.
So if
Yes,
we
audible.
if there is a load shedding here actually. So anyway, so the problem is if the patient has got a hemiplegia, he will make a circumduction of the gait. The foot will be inverted, and with difficulty the patient will make this spastic gait. Now, in case of paraplegia, there will be bilateral spasticity. In case of upper motor type of lesion, and there will be scissoring of the gait. In case of there is a problem with the proximal muscle weakness, patient can have a waddling type of gait, very characteristic of your Duchenne muscular dystrophy. So in that way, the other types of gait is the step-based gait. The sensory ataxia, what I have told, the patient will try to flex his hip as well as try to flex his knee, and it will lift up and try to allow the foot to fall on the ground like a slap. And that is the slapping. On hearing the sound, patient will actually determine where is the site of axial impact of during his locomotion. So that is your sensory gait. You can have an hypokinetic gait very classically in case of Parkinson's disease. In Parkinson's disease, what is actually happening in Parkinson's disease that the patient will be bent forward and there will be short shuffling gait. And this is due to this, as if the patient is trying to catch the center of gravity with little amount of extra speed in his cadence and the amplitude. And that is very classical of the fascinating gait in Parkinson's disease. Sometimes in hyperkinetic disorder, you can get a bizarre type of gait, but the patient will be having a grimacing of the forehead. Along with this thing, patient have a lingual dyskinesia, or the patient have a triatal toe. So that bizarre gait, along with all these features, will point towards an hyperkinetic gait. You can have a sometimes very interestingly psychogenic gait, which does not fit into a particular type of a disorder. But the bizarre gait, patient will try to fall this side, that side. Neurologically, patient will be all right. And when the patient is not noticed, the gait becomes normal. So these are the few gaits one should remember. It can be a sensory gait, it can be a cerebellar gait. Again, I am repeating, it can be an upper motor hemiplegic gait, it can be a paraplegic scissoring gait, it can be a waddling gait, it can be a step-based gait, it can be hyperkinetic gait, it can be hypokinetic gait, it can be a psychogenic gait. So these are the very common gait disorders which you often come with. Thank you, Professor Chatterjee.
Thank you. Professor Chatterjee, may I add few lines?
Sir, Professor
Yes.
Mukundan, actually, is he there?
Dr. Mukundan is there.
Huh? Actually,
Yes.
let me first come to Professor Mukundan, and I would ask him that could you just give some small clinical pointers by which, as Professor M.K. Rai has described all the types of gait, but could you just give us some pointers how a cerebellar gait can be differentiated from a sensory ataxic gait, a vestibular ataxic gait, and a frontal lobe gait? Clinical
Can we add something? Professor Chatterjee, may I add one point?
Okay, okay, sir.
Okay. Actually, ataxia, what came from the what taxis? Taxis means order. So ataxia means disorder of order. That means disorder of the coordination. So from there, the ataxia, what the came. And before ataxia, you have to rule out three issues. One, whether patient has peripheral and nerve or muscle disease, patient has basal spinal cord disease, or the basal vein disease. Then we will classify the ataxia, whether it is a sensory ataxia, cerebellar ataxia, or vestibular ataxia, or frontal lobe ataxia. Now, Professor Mukundan.
Sir, good evening, sir. Am I audible?
Yes, 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 very nicely audible.
Yes, sir. Sir, respected the President JPA Shyam Sundar, sir, Madam Dean, Madam Alaka Deshpande, and Jyotir Maipal, my friend.
Slightly louder voice.
MK Rai, sir. Can we go to the next slide? Sir, regarding cerebellar ataxic gait, the cerebellar lesion patients will have broad-based ataxic gait. The steps taken slowly and carefully. There is tendency to lurch and stagger. It is accentuated by tandem walking. Actually, we have to keep one foot, then the other, like we do in temple, so which is accentuated by tandem walking. Next slide. Whereas in case of sensory ataxia due to posterior column or dorsal ganglia lesions, they will walk with wide-based and stamping gait. So they'll advance cautiously, slow steps under visual guidance. Actually, they will stamp like with the sound. They will walk with the Bromber's positive. Walking uneven surface is very difficult. Next. In case of gait due to frontal lobe lesion, so what they will do, they'll be thinking that they'll be walking, but the foot won't move. The foot, as if the patient will feel it is glued to the ground. So it's varies from ataxic to akinetic rigid gait. They will have turning difficulty and freezing episodes. So it is called magnetic gait. They will feel as if the feet is glued to the ground. So they will have frontal lobe release signs and urinary incontinence and dementia. Commonly we see in frontal lobe lesions. Next slide. The gait due to vestibular imbalance, where in acute peripheral vestibulopathy, there is veering to the side of the lesion and veering less prominent while running than walking. Whereas in chronic vestibular failure, gait may be normal because it is balanced. The unsteadiness, which is unmarked by eye closure and rotation of the head from side to side while walking. Next slide. So this is the clinical features we differentiate from cerebellar, sensory and frontal. The falls, the first is falls, which is less common in cerebellar. Do occur in sensory, very common in frontal location. Stance, this is the early phase of this gait. It is weight-based in cerebellar. Sensory, it is weight-based stamping, variable in frontal lobe lesions. The trunk posture, leaning forward in cerebellum, stooped in sensory, and upright in case of frontal. The gait initiation is normal.
Not connected.
Normal in case of the gait initiation is normal in case of cerebellar and sensory, whereas in frontal they will have initiation. Whereas the steps, it is staggering in case of cerebellar, high steppage gait, stamping gait in case of cerebellar, in case of sensory, and actually high steppage gait is characteristic of foot drop. The high steps and stamping gait is characteristic of sensory ataxia. Whereas in frontal lobe, the steps are short steps. The speed, normal to slow, normal to slow in case of sensory cerebellar, very, very slow in case of frontal lobe lesions. Tandem walking, as I told, unable to do in cerebellar, whereas variable in sensory and variable in frontal lobe. Turning, sways away from cerebellar on the side of lesion, no problem in case of the sensory, freezing and shuffling in case of frontal lobe lesions. Heel to shin, not possible in case of cerebellar, normal in sensory, normal in frontal lobe lesions. Then associated features in case of cerebellar ataxia will have dysenergia, dysmetria, dysdiadokinesia, whereas in sensory we have decreased joint position sense, vibration sensation lost, and Romberg sign is positive. In case of frontal lobe, we have a frontal subcortical signs and frontal lobe release signs. So this is how we differentiate cerebellar, sensory, frontal lobe, and also from vestibular gait disturbances. Thank you for the opportunity.
Thank you, sir. So I think, Rimjhim, we should proceed with your history. Rimjhim.
She also complained of tremulousness for 4 years, which affected upper limbs more than lower limbs, which was also insidious onset and gradually progressive. The tremor was increased during activity upon reaching objects such as holding a cup or buttoning, unbuttoning, or negotiating food in chappal. It was not present during rest, and it was not aggravated by anxiety or sleep deprivation or use of drugs.
Okay. As we know that tremor can have various etiologies, and we need to understand what is the basis of this tremor. And in this, I think Professor Aminur will be helping us to understand how to approach. Professor Aminur.
Thank you. It's a very important part of the clinical presentation. Can you hear me?
Yes, sir.
Yes. So it's an important clinical presentation for neurological presentation for the patient. Tremor is one of the is a unintentional rhythmic involuntary movement of a joint or group of joint resulting from the alternating contracting and relaxation of muscle. So that's a unintentional rhythmic involuntary movements. It's a first things, whether it is tremor or it's myoclonus or it's chorea or like this. It's a involuntary, unintentional rhythmic involuntary movement. It occurs commonly in the hand. So we can say that tremor usually in the hand. And tremor is seen in the 5% of the population over the age of 40 years. And tremor is the most common movement disorder in the clinical practice. And how to classify tremor? Tremor classify in the several ways, but we have to classify mainly in the classify into two parts according to the relation of the movement or position of the body part. That is action tremor and the resting tremor. Can you hear me?
Yes, sir.
Yes. It is an action tremor and the resting tremor. So if it is resting tremor, it's nothing else. You can say it is probably due to the we can see that it's a neurodegenerative disorder like the Parkinson's disease. This is a resting tremor, and action tremor we're going to classify into the other ways. It's like that when any part of the body is moved voluntarily, there may be tremor. This tremor is the action tremor may not be changes the severity as target is reached. They can be occurs at very different frequencies. Usually frequency is always less than 13 hertz. And this action tremors again classify into the three ways. There's a postural tremor, the kinetic tremor, and the isometric tremor. The postural tremor is like that when the patient is working. There will be the going to work for some things. There will be the tremor. There's a posture, there is change. There will be the tremor. This is like the essential tremor. This tremor is essential is called like that. This tremor is called unknown. And another is the drugs. Some drugs we can use drugs. There will be the tremor. There's a lithium, valproate, and also the some beta agonist like this. And also there is a other condition, that's thyrotoxicosis, hypoglycemia, phacocytoma, drug withdrawal, benzodiazepine withdrawal, there will be the tremor. This will be the postural tremor. There will be the postural tremor. And this one, there is another one is the kinetic tremor. Tremor occurs during any kind of voluntary movement. And another tremor, there's an intention tremor. Intention tremor is specific for the tremor during the goal-directed movements. But that is when I say that there is you can touch your nose or you touch your fingers, there will be tremor. It's an intention tremor. It's a characteristic for the cerebral tremor. This kind of tremor we can say especially for the Parkinsonian disease like that. So the tumor can be classified in the other ways. It's like that. There's according to the frequency, according to the amplitude, according to the body part environment. According to the frequency, the low frequency tumor is the intention tumor less than 5 fibers. Medium to low to medium, 3 to 6 hours is the Holmes tumors or Parkinson rest tumor. Medium to high, there is a 4 to 12 hours. This is NS physiological tumors, and very high, this is more than 12 is the primary orthostic tumor. And another tumor, you can see the psychogenic tumor. So you can, before saying the psychogenic tumor, you have to think that other tumor you can be excluded. Other tumor with associated clinical feature you have to exclude it. And there is another is the amplitude. The low amplitude, moderate amplitude, large amplitude. Low amplitude tumor is the enhanced physiological tumor, and moderate amplitude is the essential tumor. A large amplitude is a Parkinsonian tumor, is a Holmes tumor. And tumor can be classified according to the body part environment. This is head tumor, jaw tumor, voice tumor, leg tumor. Head tumor is the essential tumor. Essential tumor, you can see that there is the head tumor, cervical dystonia, cerebral degeneration disorder, rarely Parkinson disease. So you can think that when there is, you can see that there is head tumor, and the older age, you can think this may not be Parkinson disease, because head tumor is uncommon in the Parkinsonian disease. There is another is a jaw tumor. The Parkinson is essential tumor, orthostic tumor, and head geniospasm. And another is a voice tumor. Voice tumor, you can see in the older age, we can see if the patient is much age in the female or male, there is the voice tumor. This is part of the essential tumor. And there is another is a leg tumor. Leg tumor, you can see in the Parkinsonian disease and orthostic tumor. In the older age, we can see this kind of leg tumor. So that's all. In this way, we can classify the tumor.
Dr. Rahman, my question.
Yes.
Essential tremor and cerebral tremor in disorder both have a intention tremor. So what is the difference between essential tremor?
Thank you for a nice question. Yes, because essential tremor and the cerebral tumor both are intention tremor. But you know, essential tremor we have, before saying the essential tremor, you have to exclude the other causes of the neurological diseases and other for the there's a other for the endocrine, there's a rule out. And the cerebral tumor, you have to find other sign of cerebral sign, because this if the patient have the cerebral other sign, there's the scanning speech, there will be the broad-based gait, there is dichokinesia, there will be a finger nose impaired, there is a heel shin test impaired. It's like this, there is a wide-based gait. This one, essential tumor, you can find this one. So we can, if we find the cerebral disorder with the tumor, this is the cerebral disorder. Essential, this is the tumor for the cerebral disorder. And another is when there is no cause detected, then if it is a familial inheritance, is this kind of tumor, you can find it in the essential tumor.
1.2x, essential tremor involve more the distal muscles, and cerebral tremor involve more the proximal muscles.
Yes.
So that is why when we touch a cerebral disorder patient with the cerebral disorder, when approach to the target, there is either overshoot or undershoot.
Understood.
Because
intention, there is intention.
Cannot fix it.
Yes, intention tremor. There is the intention tremor. Is reaching the target, there will be the tremor.
Tremor. Yes. Proceed.
Professor Pal, sometimes if you give some little bit amount of alcohol, that can also distinguish between because in essential tremor it actually subsides. It's a strong family history with the distal involved. So that is very nice discussion. I thank Dr. Romer for nice explanation.
One question has come whether the as a question will come later on at the end. So proceed.
We have a middle-aged lady who is coming with ataxia and tremors, and now we have to see what else she's complaining of. Rimjhim.
She also complained of slurring of speech, which started for 4 years. She had a slow, irregular speech with undue separation of syllables. Her speech had intermittent variations of loudness, whereas her grammar and sentence construction being intact.
Okay, so I again come to Professor Kera. And I would request him that this person who is having an intact grammar, but certain abnormalities in her speech, what is the speech abnormality and how we differentiate between dysarthria and dysphagias. Also, I would like to ask him, what are the structures which are involved in articulation of Sir, Professor Rai? I think Professor Rai, is he there?
Am I audible?
Yes, sir.
Oh, thank you, madam. So this is a very important, pertinent question, because sometimes the students may not make the differentiation between the dysarthria and dysphagia, because these are two separate, completely separate entities. Dysarthria means there is a problem in the articulation, and thus there is a problem in the pronunciation of the words. So it is basically a speech disorder. When the articulatory muscles are not in the proper function, we can get the dysarthria. So anatomical substrate I will discuss later on. But the dysphagia is a disorder of language. It is a linguistic problem. So the language is actually the basic thought process and ideas which are actually put into a spoken manner. By even just by a gesture, you can express your language. So language is absolutely different from that of your speech. So far as the speech is concerned, speech is mainly speech needs the articulation of the different muscles, mainly your lingual muscles, then the labial muscles, soft palate, laryngeal muscle, pharyngeal muscle, and obviously the voice box. All the muscles which are responsible for production of the sounds will be related to this thing. So we can have a dysarthria in the form of a slurred speech. That doesn't carry any meaning. The slurred may be an upper motor neuron type of lesion. It may be a lower motor neuron type of lesion. We can have a hyperkinetic slurring of the speech, like your cerebellar, which have got very classically here, she has mentioned there is an intermittent elements of explosiveness. That means that is also not characteristically controlled. The amount of the speech pitch is not controlled by the particular outflow pathway of cerebellum. As a result of which there is intermittent explosiveness, very characteristic of a cerebellar speech. However, in the cerebellar speech, it may be simply a scanning speech or a staccato speech, excessive and undue stress over a particular noun. In case of a slurred speech, when it is an upper motor neuron type of slurred speech, there is a consonant problem and you can get some amount of strangled voice. So in case of upper motor paralysis like your hemiparesis or hemiplegia, you can get a slurred speech. In case of some upper motor pseudovulvar effect in motor neuron disease, you can get like that. In the lower motor, you can get in the cranial nerve nuclei itself, the nerve itself, or the muscle itself. Even the muscle can be involved. Muscle may be directly involved by the diseases of the muscle, the tongue, pharynx, larynx, voice box, etc. Or there may be minor junction disorder like that of your myasthenia. To start with, the patient may not have the speech problem. But as the patient goes on talking and talking, there is a reduction in fatigability of the voice. Then there can be, in lower motor neuron type, there may be a nasal intonation also. So we can have simply, if you divide the speech problem, this dysarthria may be an upper motor type, will associate with another accompanying upper motor sign, lower motor dysarthria, maybe an extrapyramidal dysarthria, where there will be an extrapyramidal features. There may be a simple myoneural junction problem, you can get a dysarthria. In that way, hypokinetic, hyperkinetic, and also muscle disorder problem in the lower motor neuron type, we can divide the speech. So far as the language is concerned, we have got basically the linguistic problem, which may be due to a problem either due to the comprehension or it may be due to a Broca affection. Broca affection means where the speech will be there, but it will be very much non-fluent, and patient will try to utter the words with much difficulty and little bit amount of agrammatism may be there. So this is broadly speaking for the students I can tell the dysarthria is a speech problem, whereas the dysphagia is a language problem or a linguistic problem. Thank you. You are muted. You are muted.
Madam Alka Deshpande, is she still there, madam? Madam, I think she is not being able to hear me. Anyway, then I will.
Dr. Nandini Chatterjee, Dr. Chatterjee, there are 3 lines written here which has come to my screen. Slow, irregular speech with undue separation of syllables, which means it is a different types of words are broken and most likely cerebellar, intermittent explosive cerebellar. And grammar intake means it is not a language problem. Thank you.
Okay, so we
Professor Jagdish Prasad Agarwal has raised his hand. Sir, please comment. Professor Agarwal has raised his hand. And Dr. Sanjeev also.
Sanjeeva also has raised it. Okay.
Sir, please comment.
No, I think Professor M.K. Roy has clearly said, recently I came across a case of exertional dysarthric speech, and myasthenia gravis was the case in that case. So our residents should always keep in mind that history is very important when they are talking. And that diagnosis was missed. And when somebody looked at the chart, it was written that she has got difficulty in speech and slurring of speech as she kept on speaking. So it was a typical myasthenia gravis, and Dr. Roy has rightly mentioned that thing. I just wanted to highlight that only. Thank you.
Professor Sanjeeva.
Yes, thank you. I just wanted to add that we must not forget the last component of speech difficulty, the dysphonias, which could be due to problems at the voice box area and all, such as hoarseness that we see in thyroid disease. So this is quite, just to add to complete the component, which is not a dysarthria or dysphagia, but again, a different component. Thank you.
Yes, sir. Yes, sir. I agree with you. I agree with you.
So many good questions has came in the chat box. At the end, we will come to our panelists and we will discuss all the questions. Dr. Chatterjee, please continue.
Actually, what Dr. Sanjeeva has said, this is very important, that sometimes a hoarseness may give a clue that the voice box is involved. And then again, if you have a nasal intonation to the voice, then we may think that maybe the palate is the culprit in causing the problem in speech. So now, Rimjhim, let's hear what you have to say further.
So coming to the negative history, there was no history of vertigo, tinnitus, deafness, choking or nasal regurgitation, no history of headache, convulsion, altered sensorium, no history suggestive of cognitive decline, no history of loss of sensation in any parts of the body, no history of bladder bowel disturbance or suggestive of autonomic disturbance, no history of fever, joint pain, rash, significant weight loss, lump anywhere in the body, chronic drug therapy, and addictions to any drugs. Past history. There was no history of trauma, major operations, childhood illness, birth asphyxia, major medical or psychiatric illness in the past. Personal and social history. Patient is non-diabetic, non-hypertensive, euthyroid. She is on a mixed Indian diet. Her sleep and appetite normal. No addiction to alcohol, tobacco, or use of illicit drugs. No drug allergy, and no history of high-risk behavior. Patient is born out of non-consanguineous marriage. Her father died at the age of 35 years due to similar neurological illness. She is married for 10 years and mother of 2 children who are healthy. She is not on any oral contraceptive pills or following other contraceptive methods. Family history is significant. Her father and paternal grandfather died early due to similar neurological ailments.
Okay, then will you summarize the whole thing, the whole history for everybody so that we can go into further discussion? Please summarize the history.
So here we are talking about a 25-year-old female, non-diabetic, non-hypertensive and euthyroid, born out of non-consanguineous marriage, presented to us with complaints of unsteadiness of gait, tremulousness of limbs, and slurring of speech, which had an insidious onset and gradually progressive course. There was no features of cognitive decline, features of increased intracranial pressure, features of sensory paresthesias, weakness, autonomic disturbances. And there was a family history which was suggestive of vertical transmission. So from the history, if we try to localize the location of neurological ailments, difficulty in walking, which started with walking on a narrow passage, is an earlier sign of cerebellar disorder. And walking is mainly because of midline cerebellar lesion, which is the vermis. Tremulousness, which was present on both the limbs, both upper limbs and lower limbs, more prominent on the upper limbs, which is suggestive of lateral cerebellar lesion such as hemispheric cerebellar lesion, and the slurring of speech with intermittent explosiveness, which can indicate a lesion to paravermian area and cerebellar connections. So here we are talking about diffuse pan-cerebellar disease with a significant family history suggestive of vertical transmission. This will be my impression from the history.
Okay, here I want to ask the experts, sir. The word vertical transmission, usually it is used in case of infectious diseases. Is it also relevant in case of inheritance of disease in a neurological background? Dr. Rai or Dr. Sanjeeva, would you like to comment?
Yes, Nandini, Sanjeeva here. Thank you. What we heard so far, the history, is that this is a young lady with a predominantly a cerebellar type of disease, actually a pan-cerebellar type of involvement with a family history. We could hear that her father has died with a severe illness in the past, and there's a grandparent also having the same disease. So here, 3 generations have had probably had the same disease. So we are listening to a story of a genetic illness, which apparently is passing down to each generation. And clinical involvement is observed in all 3 generations, both males and females affected. So are we dealing with a autosomal dominant type of a hereditary genetic disease is now unfolding in front of us? Thank you.
Vertical transmission is appropriate here. Vertical transmission. Am I audible?
Voice is not loud. Talk in a louder voice.
But I think he is muted. I would ask Professor Mugundan then, is vertical transmission used in the neurological sense or in the sense of infectious diseases? This is what I'm asking. Professor Panda, Professor Jayanta Panda, he was writing something in the chat box.
Okay, proceed.
Yeah. I wanted to ask, by vertical transmission, does it mean a genetic correlation or a transplacental pathology?
Yes, that is what I am also asking her. Rimjhim,
By the term vertical transmission, I wanted to say that there is a genetic inheritance in this
Yes.
disorder.
Yes.
Not any infectious or transplacental pathology that I am indicating.
Yes, that is what I am trying to impress upon. Okay, now you proceed, I think, for the examination.
Thank you, madam.
So from history, Rimjhim tried to localize the anatomical site of lesion. So we will go for the examination. We will confirm the findings and we will proceed further the clinical diagnosis. Okay, Rimjhim, proceed.
Coming to general survey, patient is alert, cooperative, nutrition and build average. Skin examination revealed no abnormality, no bony deformity present. Breast examination and axilla examination were normal. Pallor, cyanosis, jaundice, clubbing, edema were absent. Neck examination including goiter, neck veins, lymph nodes were not present. Looking for short neck, low hairline and excessive mobility, they were not present. Pulse regular with 72 beats per minute. Blood pressure was 120 upon 80 millimeter of mercury on the left upper arm in sitting position. Respiratory rate 14 per minute. Saturation is 99% room air. Peripheral nerve thickening were not present.
Okay, I'll stop you there. You have written no bony abnormalities. So, what bony abnormalities were you looking for? Rimjhim?
Madam, as we are dealing with a case of ataxia with familial predisposition, in such conditions such as in hereditary ataxia, in Friedreich's ataxia, we can see some spinal deformities or bony abnormality which can be present, such as spinal deformity, pes cavus, etc. And for something such as in CV junction anomaly, also we can see short neck, low hairline, and excessive mobility. Also, we have to look for tuft of hair or spina bifida and neural tube defects as such in case of ataxia. That's why I mentioned deformity.
Very good.
So Jagdish, I think.
And Dr. Rimjhim, you have mentioned about the peripheral nerve thickening not present. What were you in your mind when you were saying that there is no peripheral nerve thickening?
Yes, sir. In some hereditary neurological peripheral neuropathy, we can have peripheral nerve thickening, such as in hereditary Charcot-Marie-Tooth disease or HSMN, or in some varieties of spinocerebellar ataxia also, we can get peripheral neuropathy. So that's why I have excluded.
Yes.
Very good, very good.
Very good. Dr. Sanjeeva.
Rimjhim, can you tell one thing, that why you have examined the neck so meticulously?
Neck examination, because sir, from medical point of view, we can, in a case of hypothyroidism also, we can get bilateral, we can get chronic ataxia. So I have looked for goiter, and some of the craniovertebral junction anomalies, they also have some neck abnormalities, short neck, low hairline.
Okay. I got your question. I got your answer. That is, you wanted to exclude the
Dr. Sanjeeva want to say something. Dr. Sanjeeva and Dr. Aminur. Both
only two things I like to highlight. One is your low hairline. Low hairline means you have to go up to the fourth cervical vertebra. And if it is below the fifth cervical, it is definitely low hairline. If you find the hairline below fifth cervical vertebra, it is definitely low hairline. Up to 4 we can allow. Mobility is very important. We can touch our chin to our acromial process. You can see it. You can touch our chin to the acromial process. But in the case of craniovertebral junction anomaly, this sign was actually invented by Dr. Nasir Wadia from India. This is called Wadia sign. You cannot touch your chin in the acromion. This is a very important sign for the mobility of the neck. Number 3 is your short neck. I have already told. The ratio of the height is to neck is 13:1. If it is more than that, then you can say that probably the patient is having short neck and craniovertebral anomaly. Along with that thing, we can have some cerebellar tonsillar herniation or Arnold Cherry type 1, which can produce ataxia. Thank you.
Very good.
Jyoti, this is Sanjeev. Yeah, I just want to, yeah, same point I was trying to highlight. Syndromes such as Klippel Pale syndrome and all, where we might see similar clinical picture with short neck and low hairline. So I was just to add to what Rimjhim has mentioned. Thank you.
Thank you. Thank you.
So the neck examination, you have to mention in here, especially thyroid. Thyroid you have to mention here, because you know this short neck, short hairlines, mobility, but your explanation is good. After asking Professor M.K. Roy, your explanation is good. You are looking the thyroid, but you have to, you are as a postgraduate student or trainee, you have to see the thyroid here, because hypothyroidism is one of the important part of the chronic cerebral disorder. Because still we don't go for the cerebral ataxia due to the genetic disorder. It may be other causes. It may be infection. It may be malignancy. It may be hypothyroid. It may be stroke. So many causes. Acute, subacute, chronic. There is the difference. So you have to mention here is that thyroid is important. Also, there is a skin texture. Skin texture is also important, because some malignancy goes to the brain. So you have to see that whether there's a melanoma like that, or skin is rough or thick like that. You have to mention it here. Thank you.
Thank you.
You have answered very nicely. Now proceed further.
Coming to neurological examination, she was right-handed, education, formal education up to class 8, intelligence normal, and oriented to time, place, and person. Her speech, she had scanning type of speech, dysarthria, with intermittent variations of loudness, intermittent explosiveness, and loss of prosody, while the language function comprising of comprehension, reading, writing, naming, repeating were normal. Spine and cranium examination revealed no spinal tenderness, no bony deformity. Meningeal signs were absent. Cranial nerve examination. First cranial nerve, there was no parosmia, no anosmia. Second cranial nerve, visual acuity were 6/6 in both eyes with uncorrected vision. Colored vision and field of vision were normal. On fundoscopic examination, both eyes revealed no abnormality. Coming to third, fourth, and sixth cranial nerve, bilateral extraocular muscles. On examination, there were full range of motion, no paresis. There were slow hypometric saccades. Pursuit was slow, and there was a vertical upbeat nystagmus. Other cranial nerve examinations were non-contributed.
Okay. So, Professor Panda, are you there? Professor Jonathan Panda?
Yeah, I'm here.
So, we would like you to enlighten us on the physiology of pursuit and saccade and how to test that.
Yeah, actually, while examining the third, fourth, and sixth cranial nerve, we see the eyeball movements in different directions. And here, if the movement is preserved, but the pursuit is slow, or there are saccades that indicate the cerebellar dysfunction. So here, what she has detected, the hypometric saccades as well as the slow pursuit indicates a lesion involving the cerebellum, and that further finding of the cerebral signs will tell us how to go about. And regarding the extraocular movements, she has told that full range of motions are there, and the nystagmus also told about the similar involvement.
Thank you, sir. I'll come to Professor Paul.
Okay. May I add something? Saccades and pursuits. I can give you a very simple example. Suppose I am reading something. Suddenly one mosquito is moving. Suddenly I am trying to fix my eye to the moving mosquito. The movement that is required, that is the saccades. Then I am following the mosquito where he is moving, whether he is coming to me. That is a pursuit movement. So this is this is the difference between saccades and pursuits. Actually, our purpose of the vision is to project an image on phobia in the two sides so that I can have a single vision. And to perform this, so 6 maneuver is required. One is to hold image. To hold image, required the one is fixation, that is when head is fixed. One is the vestibulo-ocular reflex. Another is the optokinetic reflex. This is to hold the image. Another 3 important physiological movement that is very important to direct the phobia to the point of interest. Suppose I want to focus on the mosquito who is moving. So 3 movement is required. One is saccades, one is pursuits, one is virgins. So saccades and pursuit basically to fix the, so that image of the desired object will fall to the phobia. So saccade is basically the rapid eye movement to bring the object of a new or a new object of interest to the phobia. And pursuit is the smooth eye movement to follow the object. This is the difference between saccades and pursuits.
And she has also mentioned about a type of nystagmus. So would you elaborate about different types of nystagmus and the types of nystagmus found in cerebellar disorders? And later we may also come to know about how to differentiate between a peripheral nystagmus and a central type of nystagmus.
Yes. Very important, because in this patient, Rimjhim has detected nystagmus.
Are you asleep, Rimjhim?
Yes, okay. Nystagmus basically same because our eye movement, basic purpose of our vision to have a single object. So because image from a particular object come to the two retina and fovea, if they do not fall in the similar point fovea, we will see the two objects. So but our purpose to see the single object, and to meet this, so many parts of the brain is acting. There is a cranial nerves, particularly third fourth is cranial nerves is acting. There is some cortical area, particularly the frontal, parietal area, different parts is acting, and also some parts of the superior colliculus and basal ganglia, and also vestibular nucleus cerebellum is acting to fix the image of the focus onto the fovea. So any disorder in this pathway can lead to different disorder, and nystagmus is one of them. By definition, nystagmus is a rhythmic, biphasic, involuntary movement of the eyes. So nystagmus has basically two components. One is the fast component, one is the slow component. Slow component is considered the pathological component, because I cannot, because the structure that is responsible for the eye movement, or rather I can say fixation of fovea with the images, that cannot hold. So eye is moving away from the object, and fast movement is the corrective movement. When the eye moves away from our desired object, then another movement brings back the eye to the desired position. That is called the fast movement. So slow movement is the pathological movement, and fast movement is the corrective movement. And this nystagmus can occur due to the disorder of the different parts. Suppose if there is a disorder of the cerebellum, we can see the nystagmus. If there is a disorder in the vestibular system, we can see the nystagmus. So this nystagmus can be classified in different ways. One is the pendular or jerky, or it is central or peripheral, or it is induced or spontaneous, or it is a physiological or pathological, or it is a fine or coarse, or it is a manifest or latent, or it is a rapid or slow, or it is a horizontal or vertical. So in different way, the nystagmus can be classified. But the basic classification is whether it is a physiological nystagmus and whether it is a pathological nystagmus. If it is a pathological nystagmus, whether it is a neurological disorder or is a non-neurological disorder. So physiological disorder, pathological disorder. Among the pathological, non-neurological or neurological. This is the basic classification of nystagmus. Very interestingly, in cerebellar disorder, we get different type of nystagmus. And what are the different type of nystagmus? One is a gauge evoked nystagmus. That means in the primary position, we will not get any nystagmus. But in a lateral gauge, we will get the nystagmus. So this is called the gauge evoked nystagmus. Upbeat nystagmus, the first phase is upward. That is called the upbeat nystagmus. What we can get? We can get the rebound nystagmus. What is this? Rebound nystagmus means suppose first component is towards right, but suddenly it changed the, when you are coming to the primary position, suddenly it changed the side, and suddenly change the side means first component become to the left side. So this is called rebound nystagmus. Another nystagmus we get the periodic alternating nystagmus. In this nystagmus, we get the nystagmus suppose to the right, first component right for 1 to 3 minutes. Then it again change another 1 to 3 minutes, first component to the left. Again after 1 to 3 minutes, first component to the right. So like this, the periodic alternative nystagmus we can get from the cerebellar disorder. Another we get the downbeat nystagmus. Downbeat nystagmus means first component towards the down, or the is the downbeat nystagmus. First component is the down, not the up. So these are the different type of nystagmus we get in cerebellar disorders.
And sir, how about differentiating between central and peripheral?
Yes. Come to the next slide. So this is another important. I told the nystagmus can be classified in different way. So there is we can differentiate between the peripheral versus central. In peripheral nystagmus, usually unidirectional, and first component is away from the site of the lesion, and more importantly, it is associated with vertigo, tinnitus, and deafness, and it can be minimized on visual fixation. And turning to the head to the direction of first component, the nystagmus increases. But whereas the central nystagmus is a bidirectional, and eye fixation has no effect on eye fixation cannot diminish the nystagmus, and there is a less vertigo, and basically it do not have any rotatory component, but peripheral nystagmus have a rotatory component. Next.
Here I would just like to ask Professor Panda that this patient had a upbeat nystagmus. Am I audible? Sir, Professor Panda?
Yeah.
Yeah, so in our patient, we had an upbeat nystagmus. So what is your comment about the possibility in this?
Yeah. We got a clear disposition about the nystagmus, different types, and central and the peripheral. So here only upbeat. This shows it's unidirectional. So mostly it's of peripheral origin, not of central origin, and maybe related to a spinocerebral ataxia what she is presenting. But here the most important clue that we are getting is slow saccades and pursuits. We have to relate both. When the saccade and pursuit are slow and there is upbeat nystagmus, and reach in a clinical conclusion regarding the site of lesion of the nystagmus.
Slow pursuits also can be explained. You come to this picture. You come to the this is, see, pursuit movement, basically the same side. This is the PPRF, same side frontotemporal, parietotemporal occipital. They give the initiation for the pursuits. Saccades is initiated by the frontal lobe, and pursued by PTO. PTO basically gives signal to the dorsolateral pontine nucleus that crosses the midline, come to the cerebellum. Cerebellum then they stimulate the vestibular nucleus. Vestibular nucleus to the opposite side PPRF stimulate and initiate the pursuits. So if there is a lesion in the cerebellum, pursuit will be weak. That we are getting.
So ultimately, all the pointers are towards the cerebellar lesion. So let us see what else is involved in this patient. So Rimjhim?
Yes, ma'am. Coming to motor system examination, Attitude of the limbs were normal. There were no atrophy present. No abnormal movements such as fasciculations, fibrillations, poria, myoclonus were present. Tone were bilaterally increased in both upper limbs and lower limbs, both proximal and distal group of muscles. Power were 5 out of 5 in bilateral upper limb, proximal and distal group of muscles, wherein in bilateral lower limbs, power was 4+ by 5 in proximal and distal group of muscles. Reflexes, coming to deep tendon reflexes, biceps, triceps, supinator, and knee jerk were present 3+, both right and left, while ankle jerk were 2+, both right and left. Superficial reflex, abdominal reflex were present, and plantar reflex were extensor bilaterally.
Before we go on to the sensory system, I would like to discuss a little about the findings on tone and reflexes, and I would call upon Professor Jagadish Agarwal, sir. We have in this patient increased tone and exaggerated reflexes. So would you tell us how or what are the pointers by which we judge whether a reflex is exaggerated or not? And moreover, what is the pronator catch?
Let's come to the pronator catch first. Like as Rimjhim has mentioned that the person is having tone is increased. It means he has got this spasticity. And if a person who has got this spasticity and initiate a movement, whether it is a supination or it is a pronation, whatever movement the person having the spasticity initiates, initially there is a there is a resistance to the initiation of that very movement. So this resistance to the very movement in the beginning is called the catch. It could be named as the pronator catch, it could be the supinator catch, or it could be just the spastic catch as well. So the reason for this may be the velocity dependence, increase in the resistance and tonic stretch of the movement. So later on, they have the movement, they can initiate the movement and then they can go ahead. This is about the pronator catch. Now the increase in the reflexes, we know that there is a classification for the reflexes, whether they are increased, decreased, or absent. We have a classification given by NINS. And we follow, most of us, we follow that if there is absence, then it is 0. But in this case, he has mentioned about the biceps reflexes, and all reflexes are exaggerated. I would like to ask Rimjhim before I answer that what does he mean by the 3+? When we say 3+ or 2+, what is in your mind when you are talking about this plus? What does it indicate? Then we'll go ahead.
Sir, we can grade deep tendon reflexes on absent and up to clonus, which is 5+, highest grade of reflex. And in measuring the deep tendon reflexes, grading from low to high, 1+ to 5, and knee jerk is usually 3+. Normally knee jerk is brisk, and for knee jerk 3+ is the normal finding, and for biceps, triceps, I meant to say 3+, because I meant to say that the exaggerated deep tendon reflexes are present.
Actually, I think other panelists can also comment on it, but this plus does not. Yeah.
Yes. Actually, reflex component are basically, if there is exaggerated, there will be decreased components of decreased threshold, decreased latency, increased power and range of the movement, prolongation of the reflex contraction, and in extension of the reflexogenic area. That means if you strike outside the tendon, you will get the reflex. So these are the components of exaggerated reflex. So even if you get the 2+, but the reflexogenic area is increased, you have to say the jerk is exaggerated.
Yeah, I mean, we simply at this level, we can just simply say that this plus does not mean that the reflex is more exaggerated or a little exaggerated. It has, I think it has nothing to do with the quantity or of the reflexes. And Dr. Paul has rightly said about the different component, which I was supposed to say, but he has already said, so it's good. But when we have to look for the reflexes, we have to look into as a whole. This is very important for the residents and we all, that they have to be interpreted in relation to the complete clinical picture. Because sometimes you may have these sort of reflexes if they are bilateral, and if there are no other pathology or no other signs, then they may be normal. So even in a children or if a child, if he has got the exaggerated reflexes, even of this nature, and no other findings, they may be normal. So if these reflexes are associated with other findings like UMN findings or LMN findings, then only they have got the meaning, or we can just say that they will have the significance. And certainly there are certain other non-neurological causes which affect the reflexes, like sleep, yes, like coma, like metabolic disorder, like even diabetes mellitus, thyroid disorders, or yes, even certain drugs. These things can hamper, or this can change the reflexes. So we have to be always considerate about all these points. And one of the most important thing which we usually say is in the psychogenic cases, conversion disorders also, you may have the reflexes increases. So what we have to see as a whole is in a total picture of the case. In this case, they may be pathological, but if any person having increased reflexes with the clonus, it is, of course, it is pathological. So I think we have, and if there is an isolated, in like one root is involved and there is a hyperreflexia, then of course that becomes significant and we'll have to find it out. And the component Dr. Paul has already explained, there are different components like if we know the pathway or the monosynaptic reflex arc, then we can just interpret on all those.
Thank you, sir. So Rimjhim, now from
Chatterjee, Professor Chatterjee, we in the same breath, I think it's a nice explanation by Professor Agarwal, but in the same breath, pronator catch and pronator drift, these are two words. So little bit about the pronator drift. The pronator drift, I think, should be mentioned because it is a very common question asked by the examiner often in most of the examination. The pronator drift is in case of an upper motor neuron lesion, especially in the parietal lobe lesion. If you just ask the patient to put both the hands straight away with the palm facing up, you will find that at some time the patient will rotate the hands in a pronating manner. And with the subtle weakness of our motor neuron lesion, you can find that there may be an upper motor neuron lesion. But if the hands in that position comes to midway between the pronation and supination in a sideways, it means that the patient has got some amount of incoordination, and that may be due to, that drift may be due to cerebellar lesion. So that is a very important point to know. Thank you.
Yes, sir. Actually, if the hand drifts outwards and it may go outwards, then it signifies that there can be a sensory ataxia or there may be a cerebellar lesion. That is incoordinate. Yes, sir. Thank you. Thank you very much. Now we go back to Rimjhim and we will hear I think the last part of the revelations about the case.
Okay, madam. Sensory system examination. Coming to spinothalamic tracts, including croup touch, pain and temperature, they were normal. And posterior column sensations, such as joint position sense, vibration and fine touch, they were also normal. Other systems examination revealed no obvious abnormality. Coming to cerebellar system examination, titubation was absent. There was presence of coarse action tremor, which was present perpendicular to the action of motion, and the amplitude increased on reaching the target object, affecting upper limbs more than lower limbs. Finger nose finger test revealed past pointing, which was more on the left than right. Dysdiadochokinesia were present left more than right. Heel shin test positive, left more than right. Bilateral pendular knee jerk present. Toe finger test positive, left more than right. And Romberg test negative.
So, what's your impression after you have described the whole examination of the nervous system? What is the anatomic localization from your part?
From history, we concluded that it may be a pancerebellar disease, and in examination also we got corroborative finding which suggested the involvement of midline, intermediate and lateral cerebellar structures, both bilateral, suggesting of a diffuse cerebellar disease, and involvement of the corticospinal tracts bilaterally. So this is a slow, gradually progressive disease with selective and symmetrical involvement of cerebellum and its connection, pointing towards a neurodegenerative disease of the cerebellum with autosomal dominant pattern of inheritance. So my provisional diagnosis after...
Let it be, I'll ask you. Okay. So, so what she has said is that ultimately all of the clues are pointing to a diffuse cerebellar disease. Also, along with it, there are involvements of corticospinal tract. Now, for all the students, a little bit about the functional anatomy of the cerebellum. Firstly, as you all know, that the cerebellum has two cerebellar hemispheres. There's a median vermis, and anterior and inferiorly, there is a flocculonodular lobe. Now, functionally, actually, the cerebellum can be of three names can be given. One is the vestibulocerebellum. Come to the next slide, Rimjhim. Yes, the vestibulocerebellum, which is essentially the flocculonodular lobe. Then the cerebrocerebellum and spinocerebellum. Now, why functional? Because each of these components, they control a part of the cerebellar function. Though it is not so easy, there may be overlapping of functions, but as you can see, the vestibulocerebellum, which is the flocculonodular lobe, it is essentially linked with extraocular movements, and if there are disorders, then we may get abnormalities in various eye movements and nystagmus. When we have abnormalities of the spinocerebellum, in that case it is seen that there are patients who will be complaining of problems in posture and balance, and they will also have difficulty in locomotion. Patient may complain of a truncal ataxia, mild wide-based gait, and if it is severe, they may even be unable to sit properly due to ataxia. Whereas when we are coming to the cerebrocerebellum, which essentially deals with the cerebellar disc, then we find that there is a problem of coordination of the appendage, or appendicular coordination is maintained by the cerebrocerebellum. Now, there are two main gross divisions that you should keep in mind. One is the midline cerebellar syndrome, and another is the hemispheric cerebellar syndrome. So, what are the features of the midline cerebellar syndrome? When your patient is having a disease which is predominantly involving the midline structure, then he or she, actually a classical example is degeneration of the cerebellum to alcohol. They may have difficulty in tandem gait, mild wide-based gait, and more pronounced when the patient tries to turn. If this disease becomes severe, then the patient may have a staggering gait and a truncal ataxia by which he is unable to stand keep on swaying, and even may not be able to sit tall. In these patients, usually the tone and reflexes may not be affected, and their extremity test may even be normal. So you have a patient who has a more or less normal Lurch test, but he is unable to walk. On the other hand, if your patient is having a cerebellar disease or hemispheric, that patient will have problems in coordination of the appendix. There will be tremor. He will have fast pointing, dyssynergia, dysmetria. All these things will be explained in detail by my co-speaker, Subodhi Bhutto, later. So I don't want to go into too much detail. What I want to impress upon the fact is that cerebellum has functional areas, each are committed to look after a particular function. The eyes, ocular movements by the vestibulocerebellum, the midline structure looking after the axial coordination, and the hemisphere looking after the appendix. So now we move on to the next part where I think first you describe how the gait of this patient was, Rimjhim, and then we'll come to Dr. Sanjeeva, who can explain to us the physiology of gait.
The patient had a wide-based stance. She had a wide-based gait with initiation of gait being normal, speed slow, lurching or reeling, and irregular steps with a tendency to fall on either side.
Okay. So, sir, Professor Sanjeeva, are you there?
Yes, Nandini, thank you. Yes, I'll take a couple of minutes to tell you something about human walk or gait. Say, I'll go into the evolutionary perspectives for a couple of minutes because it is important. The Homo sapiens or humans evolved over a period of many millions of years. So initially, they were like any other apes. They were on trees and on the ground on all fours. Later, at some point, they became bipedal. So that is the beginning of bipedal walking, somewhere around 4 million, 6 million years ago. And thereafter, the humans have an elegant, very coordinated, and very useful walking, which freed the arms, both arms, so that the man suddenly later became a technologically advanced person. In talking about physiology, I would like to start with mentioning few important things. One is the anatomical arrangement for bipedal walking or gait. So the gait is involved in hip movements, the movements of the hip joint, knee joint, ankle joint, and the foot joints. So all these are involved in physiology or the anatomical support for walking. Then, of course, the control of walking is by three systems. One is the pyramidal system, which is helping us with the control, the voluntary control. Then we have the extrapyramidal system, which is regulating especially both the voluntary and involuntary movements of the walking or the gait. And then the cerebellar system looking after another aspect of the regulation of gait. Then, of course, the brainstem, spinal cord, all are involved in the execution of ultimate gait. So looking at, so those are the neural control of gait. All are important. Now, if there is any lesion in any of these areas, for example, the cortical lesions, we have the hemiplegias, hemiparesis. Then, of course, the basal ganglia involvement or the extrapyramidal system involved. We have certain different types of gaits, as we discussed earlier, the festinant gait of Parkinsonism. Yes, and then we are discussing now of this patient, the cerebellar disturbance, which is giving a cerebellar gait. So any derangement in any of these neural controls can give rise to a certain disorder of gait. And also to tell you about one importance of what are the steps of a coordinated gait. It is not available in the slide. Yes, this is the one. Yes. So gait has mainly two phases. One is the stance phase and the other one is the swing phase. The stance is when, if we consider one leg, the movement of one leg, the stance phase is usually about 60% of the time it is in the stance phase, and about 40% of the time it is in the swing phase. If you consider, let us say, right leg. So you start with the heel strike first, and thereafter you keep the entire foot flat and start giving the weight bearing. And then we come to the mid stance, where we give entire weight of the body on one leg. And this is an important instance when this is the time when we swing the other leg, as well as when we give the entire body weight onto one leg. Actually speaking, at this time, this knee might take up 1.5 times the body weight onto that knee. So that is when somebody might get all these osteoarthritis and all, they might get the entire burden on knee joint. Going into our physiology of gait, then comes the heel off position. We start to get the heel off, and thereafter we take the toes off, and those are the stance instances. To go back, we put the heel first, heel strike, then the flat foot situation, then the mid stance, we are giving the entire weight, then we start heel off, and then we start swinging. Thereafter the swing, the mid swing, terminal swing, and we put the heel back on the floor. And this is nicely synchronized. If we take the mid stance position, at that point we put the entire weight on one leg, and the other one is the hip is tilted up to clear the ground, and the other one is swinging. And if we look at the heel strike, and at the same time the other leg is having a forefoot takeoff, is both happening together. When you are putting the heel strike, the other leg is having the takeoff of the forefoot. So that is the physiology, the stance phase and the swing phase. And so those are the phases of an elegant and a very coordinated gait. This is helped by all the muscles, all the nerves that are supplying the lower limbs, the muscles of psoas major and the gluteus, the thigh muscles, leg muscles, all these are very coordinated manner, supporting us for a very coordinated and elegant walk. That is about all from myself for physiology. Thank you.
Thank you, sir. Now, Shubhadeep, are you with us? Shubhadeep Gupta? You are?
Yes, ma'am.
Okay.
Yes, ma'am.
Okay, so we are eager to hear from you. Is the slide? Is the slide? Yes. So Shubhadeep is also going to enlighten us that how we examine gait, what are the variables that we need to see, and also he'll give a brief overview of how to test cerebellar function. So Shubhadeep, go on.
So good evening, teachers. Whenever we examine a patient and whenever we describe an abnormality, we need to quantify them, for which the definitions have come up. For example, by cadence, we mean the number of steps per unit time and also the regularity of it. By step length, we mean distance between successive heel strikes. By stride length, we mean distance between successive heel strikes of the same limb. By step height, we mean vertical clearance of the foot. by width of the base, we mean distance between medial malleoli of it during standing and walking. Kindly change the slide. So normal gait has almost substrate of entire neuroaxis, starting from cognition, sensory input, sensory motor integration, to postural reflexes, to the efferent system, not to forget the joints and ligaments, and obviously cardiopulmonary function. Move on.
This was
So
already.
this is again the slide that has shown. So I am skipping it. Yes, this is a very important slide, and this is how history and physical examination should be recorded. In history, we must say history of falls, for example, progressive pancreas palsy. Going down the stairs is very important because it gives a clue of quadricep weakness, joint pain and swelling. We obviously need to note diurnal variation in ataxia, in dopamine responsive dystonia. Going upstairs is very important to note the knee extensor weakness. There is history of neuronic claudication in lumbosacral radiculopathy. Tripping of feet can be a feature of both UMN and LMN lesion, and there are history of drug intake. In the physical examination, we must not miss the musculoskeletal examination. Cognitive function assessment is very important because it is the cornerstone for planning of movement. And then what Jonas had said, we have to examine motor sensory system in detail to call it ataxia in the first place. Now I am coming to the main point regarding the examination of the gait. From the point the patient is standing up from the chair, please go to the previous slide. We have to note the trunk posture. Go back to the previous slide. The trunk posture, the stance, we know that stance vibrates in cerebellar gait. The shape length is very small in case of Parkinsonian disease. The cadence is irregular in case of cerebellar disorder. Fascination in Parkinsonian disorder. Arise from sitting may be very difficult for Parkinson patients. Start hesitancy is a feature of frontal lobe gait. Step height may be increased in peripheral neuropathy. There is associated arm swing is decreased in Parkinsonian disorders, and we all know difficulty in turning is a classic feature of Parkinsonian gait. Now let me quickly elaborate the types of gait and how to differentiate them. Next slide. Yes, I want to emphasize the two gaits. Others are visible on the screen. In the cerebellar and the sensory ataxia. The step length in ataxia is always short, but cerebellar ataxia is variable. The step height is increased in sensory ataxia to provide the vestibular input to the brain, but it is variable in cerebellar ataxia. In cerebellar gait, obviously irregular or drunken gait, the base is wide in both, and diurnal variation is a telltale feature of sensory ataxia. But again, any gait which is disturbed will be difficult to execute in the dark. So diurnal variation is not a sole feature of sensory ataxia, but when it is out of proportion, it can give a posture column involvement. Now let's move to the next slide, cerebellar functions. So these questions are asked already. I tried to answer in the question and answer session regarding the tubation. It's a rhythmic head tremor. If you want to localize it at all, the localization will be the vestibulocerebellum or the midline cerebellum, where it is related to vestibular nucleus. So from the vestibular nucleus, the second order neurons go to various directions, of which cerebellum is one, and that is very important to make our head steady. In case of cerebellar disorders, there is titubation because our head is not stabilized. Next slide. We have to observe the deviation of limbs, particularly when the eye is closed. In cerebellar lesions, there is drift of outstretched hand laterally to the side of vision. intramural tract lesion, the arm drifts downwards with accompanying of pronator drift, and we know in parietal lesion, the arm rises and drifts upwards. Another very classical finding of cerebellar lesion, because there is no coordination between the agonist and antagonist. The antagonist muscle would not stop a movement when a sudden release of resistance, and the arm will fly upward vigorously due to impaired checking. This is a problem in the cerebellar outflow system. Next slide. Yes, another very classical.
I'm interrupting you a little
Yes,
bit.
ma'am.
So when you are testing the patient, you said that the hand will fly off. So what to do during the examination process so that
Yes.
the patient doesn't hurt himself? You have to say that.
Yes, one point is very important, that the patient's face has to be saved from the injury. So the patient's other hand or the examiner's hand should be placed in front of the patient's face to prevent the injury to the patient's face.
Or it can be put on the shoulder. Can a hand be put on the shoulder of the patient so that when his hand moves, it doesn't hit his face?
Yes, madam. This can also be done. The intention is to save the patient from injury from his own arm. So anything can be done to make sure of that. So another classical example of cerebral disorder where there is lack of smoothness, irregularity of the rhythm. One point I want to mention here, don't be upset if you can't find it in few initial steps. Can be initially normal. It becomes clumsy after a few attempts and where the attempts are made in a hurry. So this is again a disturbance in the agonist-antagonist coordination.
Clavicle.
So in the finger notes test, we get to know a lot about the cerebellar anatomy, starting from intention tremor to dismay to pass pointing. Now, cerebellum is the organ which guides the motion where to stop. Now, this accuracy is lost. It can fall short. It can go beyond what is intended. The smoothness is lost, and it becomes irregular. And to find the object, there is steady to and fro movement which gives rise to the tremor. Tremor is always the dysfunction of cerebellar efferent pathways, and symmetry is the inaccuracy of speed, power, and direction of movement. Regarding the Hill-Syn test, which is a favorite of examiners and also of students, we need to differentiate between the sensory ataxia and cerebral disease. In sensory ataxia, it will be very difficult to look at the knee. There will be groping of the heel of the other limb around the knee to find the knee. And in cerebral disease, though the knee can be found, while reaching the knee, there will be intention tremor which makes the activity very difficult, and there will be clumsiness of movement while moving the heel and the skin. Now, Sir has described it in detail, but I want to mention the pathophysiology of gauge of nystagmus. It is a faulty neural integration due to vestibulocerebellar lesion, leads to a pulse mismatch. A pulse is an activity of a bus neuron, and the step is the activity of the integrator neuron. Here the problem is with integrator neuron, which is the connection between the vestibulum and the cerebellum. So there is gauge-evoked nystagmus, difficulty to maintain an eccentric gauge. Regarding this case, this patient has a downbeat nystagmus, if I am not wrong. Was it downbeat?
Upbeat nystagmus. Upbeat nystagmus.
Upbeat nystagmus, yes. The localization of upbeat nystagmus in cerebellar disorder is the anterior midline or anterior vermis, where the localization of downbeat nystagmus cerebellar disorders is the posterior vermis. And the localization of periodic alternating nystagmus is the uvula, the nodulus, and their vestibular connections. Next slide, please. So, as said, cerebellar nystagmus cannot be suppressed by fixation, and it is bidirectional, and amplitude is greater when the patient looks at affected side. Now, one thing I mentioned here that this patient had exaggerated reflection and plantar reflex, which is not common finding pure cerebellar disorder. Cerebellar disorder in presence of cerebral disorder can give rise to such findings, but there is always hypotonicity in isolated cerebellar disorder, which gives rise to near. The number of to and fro movements are controversial, but it is accepted as 3 to and fro movements of the hanging lower limb after tapping the patellar tendon. Now, what I want to mention here, which is not been discussed, is the higher function of cerebellum. Cerebellum is also implicated in cognition, and we have to remember the mnemonic of ELISA, ELISA, E for executive function, which is a function of the neocerebellum bilaterally, LI for linguistic function, which is just opposite of the brain, right side, right posterior cerebellum. There is the spatial or visospatial function of cerebellum, which is just the opposite of the brain. It is situated in the left-sided cerebellum. And A for affect. The midline cerebellum is also known as limbic cerebellum, so which has a very good connection with limbic system. So there can be a disorder of affect in midline cerebellar disorders. Thank you.
What is your provisional diagnosis?
The provisional diagnosis of this case is spinocerebellar ataxia, probably autosomal dominant pattern of inheritance.
Just enumerate the points in favor.
Madam, can you repeat?
Why do you say what are the points in favor from your history and examination?
Okay, this patient had degenerative disease suggestive of pancerebellar disease and selective involvement of cerebellum as well as and its connections and corticospinal tracts with positive family history that suggests an autosomal dominant pattern of without any sex predilection. So that thus I would like to say the provisional diagnosis of this case as spinocerebellar ataxia.
Is Professor Palani okay, sir? Professor Agarwal wants to say something.
I just wanted to know from Dr. Rimjhim that when you are giving the provisional diagnosis of a spinocerebellar ataxia, there are so many spinocerebellar ataxias. So, and there are different presentations as well. So if you have to make the differential diagnosis, which spinocerebellar ataxia you will keep? Forget about the autosomal dominance or the genetic study, whatever you might have done or you are going to do. So
Sir,
if I say, in this case, like for your ease and for the time saving, if I say that it is a variant of Friedreich ataxia,
Friedreich ataxia will have a autosomal recessive type of inheritance and it will be present in younger age group and the patient will have such diabetes or cardiomyopathy associated features. Along with it, it may have some bony deformities, pace cavers and peripheral neuropathy, etc. will be present in case of Friedreich's ataxia.
It is in the classical Friedreich ataxia, whatever you are describing, but in a variant of Friedreich ataxia, there may not be bony lesions, there may not be diabetes, there may not be cardiac involvement. Other than your penetration or inheritance, whatever you are mentioned, yes. Is there any other point which deny the differential diagnosis of Friedreich ataxia or a variant of Friedreich ataxia?
Here there is a dominant autosomal, every generation of the paternal side of the family has been affected without any sex predilection. But in Friedreich's ataxia, it's autosomal recessive type of inheritance which can be seen. So that will be my point against. And also a younger age of onset in case of Friedreich's ataxia. And the patient is usually wheelchair bound by the time the disease has progressed.
What about the posterior column involvement?
And posterior column involvement will be there in Friedreich's ataxia.
Okay, go ahead, please.
Another DD is coming, multi-system atrophy, where you will get both corticospinal tract finding and cerebellar sign. What are the additional findings in MSA?
But that there will be, sir, some autonomic disturbances in multiple system atrophy.
And also features of basal ganglia lesion,
Basal ganglia lesions.
lesion, brainstem lesion, these are found in MSA. Okay, proceed. Proceed.
Palaniappan still there, sir?
Yeah.
Yes, Dr. Palaniappan is there.
Yeah, tell me.
Actually, I wanted you to enlighten us on the causes of chronic cerebellar ataxia.
Yeah. Thank you, my Paul, and everyone for giving me this opportunity. So whenever you are seeing the ataxia patient, treatable, non-treatable, slowly progressive, and this is the typical case of MD final year PG student exam case, Friedreich's ataxia. So we should know the differential diagnosis of chronic progressive ataxia. So the commonest cause, various studies, various publication wise, the commonest cause is multi-system atrophy, cerebellar variant. The next one is the Friedreich's ataxia, confirmed genetic causes, and sporadic adult onset ataxia of unknown etiology, and post-infectious cerebellar ataxia, any post-viral or post-bacterial, or post-viral is very common, post-bacterial infection, and post-tuberculosis etiology, basal, that's cerebellar ataxia. You can get it with tuberculosis meningitis, but it's rare. And alcoholic cerebellar degeneration, chronic alcoholism, chronic history is not there. So alcoholic cerebellar degeneration is one of the important cause. You have to give a differential diagnosis. And superficial siderosis and toxic causes chronically, but usually the very important thing, cerebellar ataxia, the eptoin, that is phenytoin sodium, chronic intake. But neurologists usually nowadays they are avoiding. But if there is a patient is having unsteadiness gait for a long period, they will reduce the dosage. So definitely it will not be there. So toxin related cerebellar, chronic cerebellar ataxia, and superficial toxic causes and inflammatory causes, and paraneoplastic cerebellar degeneration. Paraneoplastic cerebellar degeneration, one of the important differential diagnosis, and progressive ataxia with hypertrophic olivary degeneration. It's also very important. And amiodarone toxicity, usually amiodarone toxicity, that is hyperthyroid, hypothyroid, all the other things will be there. But always when you are diagnosing Friedreich ataxia, always rule out any associated problem in the cardiovascular system. This patient is not there. So hypothyroidism, it will not be the important cause for a chronic symmetric progressive cerebellar dysfunction. But these are all the important things. There's a multi-system atrophy cerebellar variant and confirmed genetic cause, that is a Friedreich ataxia, autosomal dominant or recessive anything. And sporadic adult onset ataxia of unknown etiology, post-infectious cerebellar ataxia, alcoholic cerebellar degeneration, and superficial siderosis, toxic causes, inflammatory causes, paraneoplastic syndrome, and progressive ataxia of hypertrophic olivary degeneration. So everything can be confirmed by MRI brain as well as MRI spine. So always when you are treating as a physician, general physician, treatable and non-treatable. When you are treating, whether you can able to alter the progression and how will you manage all the things, you have to keep it in mind. This patient Friedreich's ataxia, so only thing, muscle relaxation, other things, something you have to give, you cannot alter, but
some form of treatment, he can postpone the death. So this is a typical case of MD general medicine postgraduate cases. We have presented many cases. So this is the point I want to mention to the postgraduate student. Thank you very much, Nandini. Jyotir.
Thank you, sir. Now I think we have really come to the end. Please confirm your diagnosis, Rimjhim.
Depends on the determined by the distance.
Okay, proceed.
Yes, madam. Routine investigations of this patient revealed no abnormality. MRI of the brain with contrast revealed no focal intracranial abnormality with prominent cerebellar folly due to cerebellar atrophy. Along with MRI brain with MRI spine with contrast reveals no obvious abnormality. Depending on these findings with significant family history in this patient, we performed a whole exome genome sequencing of this patient, showed CAG repeats of ataxin-1 gene of pathogenic variants, thus genetically confirmed this patient to be a case of spinocerebellar ataxia type 1.
One thing is Professor Aminur Rahman there, sir?
Yes, yes.
Sir, would you like to comment on the MRI brain of this patient? Whether this is what is found in what type of...
Thank you. It's a very, very nice MRI. But you know, in spinocerebellar MRI, so in here we will find only this one, this sagittal section. Yes. So we need the axial section also, because if you want to see that, if in here you can see only the cerebral hemisphere and folia, but we do not see there's the the brainstem. We do not see the brainstem here, because there are several types of cerebral ataxia. There is a more than 36 variant of the cerebral ataxia. So most common cerebral ataxia is the spinocerebellar ataxia is 3. That is the and the Friedreich's ataxia. So in this point, we can see only the folia. There's the cerebral hemisphere, but we cannot comment about the the brainstem. There's pons, you cannot see the pons. In cerebral hemisphere ataxia, can you show me my slides? I sent the slide to you. Can you show my slides?
I did not get this.
I sent some slides to you. There's so it is very.
I did not get the slides from. I think.
Can I go for the slideshow? Can I go for slideshow?
Sir, Professor Paul.
I sent some slides to Professor Paul.
Sir Paul.
Yes.
Sir. Sir,
hello.
Can you see me? Can you show me the slides? I sent 6 slides of MRI.
Okay, you show the slides, because this slide is, I think, finished. Professor Nandini?
Yes,
I think
this slide.
This part is Rimjhim's part is finished, so you can share your slides.
Stop. Sir, Professor Aminu, can you show your slides?
Okay, slide show.
Sorry, actually.
You show your slides.
Incorporate in this one.
Have you seen this slide?
Yes, they are visible.
Can you see?
Yes, sir. You make a full screen.
Yes. So I can show you here the 6 slides. So this common spinocerebellar ataxia I can show in the MRI. So it's a spinocerebellar ataxia. You see Rimjhim, Dr. Rimjhim show me this slide, the sagittal view. There is a atrophy of the cerebral hemisphere. We find in here, but in here, if you want to see the brainstem, you see there is a pons in here. It is a fourth ventricle, and pons is here, and in the pons there is a lesion. Is a degeneration of olivopontocerebral pathway. So we'll find in here there is a special there's a hot cross bunny appearance. Hot cross bunny appearance in the pons. But in spinal ataxia, there is no changes in the spinal cord. And another spinal ataxia type 1. You see, so in here the pons is there. There is a the degeneration of olivopontocerebral tract. So there is a hypo intense, and there is also hyper intense, and there also there's a hyper intense. It's a hot cross buns appearance. This is specific for the specific for the spinal ataxia. We'll find the defined this kind of relation, but in here, especially this way in here, we cannot find any lesion in the spinal cord. So spinal cord is spare here. You see there's a spinal ataxia type 2. In here is sagittal view, and there's an axial view. So in sagittal view, we find this. There is a there is a there's a loss of volume of the cerebral hemisphere. And also in the significant brainstem atrophy, not the pons. It's also the midbrain, also the pons, and so also the medulla. There is all the part of the midbrain is there is a destruction. There is a loss of volume of the brainstem. So in this here, there is you see that in the pons there is also, especially this pons is too much atrophied here. It's not typical. There is a hot cross bun appearance, but this is grossly atrophied of the pons, and also other part of the brainstem.
Sir, sorry. Actually, slides are not showing, sir. Actually, your slides are not changing. So, would you please, sir, unshare it fast? Stop sharing, sir, fast.
Okay.
Now you please start sharing again. You will get one full screen option. You will click on that, sir.
Can you see?
Yeah, in the full screen option. Yeah, now it's fine, sir.
Can you see now? Okay.
Yes, sir. Yes, sir. Now
okay.
It's fine.
So I can repeat it again. I told you before that there is several types of spinal ataxia. The number is 1 to 36, probably more than that. And but this common spinal ataxia we'll find in the day-to-day practice. There's a spinal type 1. In here, you see the gross loss of volume of the cerebral hemisphere, but you see the brainstem near to intact. Especially in here, that there is a loss of lesion in the olivopontocerebral tract. Olivopontocerebral tract. After destruction of the olivopontocerebral tract, there is a special characteristic appearance. It's a fourth ventricle. This is the pons. In here, there's a appearance of the like a plus appearance. This is a hot cross bun appearance. There's upper part and the lower part of the pons. There is a line, demarcating line, and there is the central line. Is there is a bun appearance, hot cross bun appearance. It's specific for the spinal type 1. And in here, especially the spinal cord is usually intact in here. Spinal cord, if you go for the MRI of the spinal cord, you do not find anything. If the spinal cord seems to be normal. And this one same other patient is spinal ataxia. That you see there is the folia in here. But there is a what cause mass appearance. So important like they say is a specific characteristics for the spinal ataxia or spinal ataxia, and another part of brain stems. The other part of brain is in based near to normal. Another spinal ataxia type 2. In here you see there is a gross atrophy, gross loss of volume of the brainstem. The midbrain is there is a midbrain, the loss of volume. The response to this olivary nucleus, there is loss of volume. Also the medulla, there is loss of volume. And specific in here, the pons is inferior. The pons demonstrated a flattening of the flattening. This one, you know, this is a pons, and in here there is a foot ventricle there. So there is a flattening of the pons. The pons is grossly atrophied here. So from type 1 to type 2, there is difference between the brainstem involvement and brainstem involvement. And in here also there is a slightly volume changes of the spinal cord. And spinal type 3, there is a showing the gross cerebral atrophy and enlargement of the fourth ventricle, along with the spinal cord involvement. Spinal type 3, so more involvement of the spinal cord. There is the cervical as well as thoracic part of the spinal cord involvement here. And another is spinal ataxia type 6. And in here you see MRI of the T1 weighted MRI shows the atrophied cerebral hemisphere, and then axial the axial image shows the cerebellum without brainstem involvement. In here brainstem is normal. So type 1 and type 6, the difference is type 1 and type 6 difference is here. The brainstem is intact here, but in type 1 then brainstem involved, especially in the pons. So type 1 and type 6, both characteristics difference by the involvement of brainstem. In type 6, there is no involvement of brainstem. And another common ataxia, this is edit ataxia, this is fatigue ataxia. We'll find it more common in the world. There is a musculoskeletal involvement, skeletal deformity within the cerebral sign and the plantar. All the reflex are increased. This one, this type of ataxia, you will find the cerebral hemisphere near to normal, but involvement is more common in the spinal cord. Spinal cord involvement here is the more common than the involvement of the cerebral hemisphere. So all of these are the common MRI presentation of the cerebral ataxia. Thank you.
Sir, now over to Sir Jyotirmoy Pal to conclude the session, this class.
Thank you. Very nice and elaborate discussion, and particularly the clinical point of view. And spinocerebellar ataxia, Dr. Paliyappan has correctly this case is given in the MD postgraduate. The postgraduate student who are present in the webinar, or we'll put the YouTube recording in our YouTube of ICB YouTube. Later on, they can be updated with the different issues of the cerebral disorder. So with these few words, I conclude the session. I am very thankful to all the dignitaries, faculties from the different countries who are present and given encouraged to us and also enlightened to our students. I hope again in future in all the webinar I will get them be connected and will help us to develop the regional forum of medicine consisting of these 5 countries. So I am thankful to all of you, my students, my teachers, my colleagues, and I am especially thankful to Dr. Rimjhim and Professor Nandini Chatterjee. Without their help, it was not possible to conduct such beautiful case discussion session. Thank you all. Thank you.
One minute, Jyotir. On behalf of South Zone and South Mid Zonal convener, my heartiest thanks to my dear friend Dr. Jyotirmoy Pal I am also eagerly awaiting to involve all the SAARC countries' leaders, topmost leaders. We are conducting every week, that's a PG masterclass. We would like to involve all the SAARC country people also. If Jyotirmay Paul is keen to involve in this our program also, South Zone and South Bengal PG masterclass also, I am ready to do that also. It's a really wonderful session. It's involving not only neuroanatomy, physiology, everything, word by word. It's a detailed class. I enjoyed really. In my postgraduate classes, one neurologist, actually, Captain, he taught like this only. All the neuroanatomy, physiology, one by one, history taking, physical examination, and one by one, how do you differentiate all the things? What are the four important differential diagnoses? How to differentiate between the four? Everything they taught it when I did MD General Medicine. And as the very, very commonest cerebral you are thinking in terms of always lateral medullary syndrome. Also, you have to rule out many times. Acute cause, you have to always rule out. It's a slowly progressing chronic disease. So it's a typical exam case. Thank you very much. And all the SAARC country leaders, they did a really wonderfully very well. And Nandini detailed neuroanatomy, everything. Thank you very much, my dear friend Jyotirmay Paul, for a wonderful feast, scientific feast. Thank you very much.
At the end, I am very proud of Dr. Shubhadeep Gupta. Once he was my MD PG student, now he is expert in neurology. Thank you, Shubhadeep. And lastly, I convey my thanks to Professor Alka Deshpande, Professor Shyam Sundar, and Professor Senaratne for giving this opportunity to hold such a webinar. Thank you all.
Thank you very much.
Sir,
Thank you very much.
Bye-bye.
Thank you,
sir. Jyotirmay sir.
Yes.
Sir, from
Yes,
student side, I want to mention one thing, that the specialty teaching which is provided in this platform is of another level. This almost at par with the DM level. So as many as students will get involved in this, the level of education will increase to tremendous height. I am really astonished to see the height of presentation here. Thank you, sir.
Thank you. Thank you. Thank you,
Thank you,
Nandini.
sir.
Can you say something?
Thank you, Professor Jyotir.
Bye, Nandini. Bye.
Yes, sir. Thank you.
Thank you, everybody.
Thank you. Thank you.
Bye.
Bye.
Thank you.
Hi, I'm John Brassey and I'm the creator of the TRIP database. TRIP is an online database that helps connect users with high quality, evidence-based clinical content to support their work. TRIP is fully web-based and is optimized for both mobile and desktop browsers, so you can use it on your PC, tablet or mobile phone. Users can search an unrivaled collection of evidence from clinical guidelines, systematic reviews, regulatory guidance to randomized controlled trials and other primary research. Let's jump straight in to show how easy it is to get great results in TRIP. This is the homepage of TRIP. You'll notice a yellow theme. This shows it's the Pro subscription version. But the way to use TRIP is the same if you're using free or Pro versions. Now let's do a simple search for croup. As I type, you'll see a drop-down appear with search suggestions. I'm going to ignore these and simply hit the search button. You're now seeing the results page with three main areas. At the top is a search box area reflecting your initial search. On the left-hand side is a search filtering area which can help you refine your results. And in the middle are the actual results. To see the article of interest, in this case the top result, you simply click on the title and the result opens in a new window. One thing you might have noticed is the use of the colours. These appear under each result and in the search filtering area. This reflects an important concept in evidence-based medicine, the evidence pyramid. This helps to convey that some evidence is better than others. In this pyramid, the high-quality secondary evidence is at the top and is coloured green, and as you work down the pyramid, the colours change, reflecting the different evidence types. At TRIP, we're focused on delivering the best available evidence, so favour secondary evidence. We much prefer quality over quantity. Now, if we look back at the search results and scroll down, we can see that under each result is a pyramid, with a coloured band representing the place in the evidence pyramid. Alongside that is a coloured lozenge with the type of evidence, for example, systematic reviews or evidence-based synopsis. This principle is carried over into the filter area. Here you can restrict your results to a particular type of evidence. So I may be mainly interested in systematic reviews, so clicking here restricts the results to just systematic reviews. And you can click again to remove the selection. That's all for this video. I hope you found it useful. Thank you.